Welcome to this video on acute coronary syndrome, or ACS. This video is just kind of going to explain how to break down the three different types of acute coronary syndrome, because a lot of times when a patient is admitted to the hospital or comes into the emergency department, it may be said that the person has acute coronary syndrome, but it can be three major different things. So let's break down the term first, acute coronary syndrome. What's acute mean? Well, it means it's something that happens all of a sudden. It's not something chronic or something that's been lasting a long time. Coronary, well, of course, that relates to our heart and the coronary arteries that carry oxygenated blood to our heart muscle itself. And then syndrome. A syndrome is just a collection of symptoms. So we know this is a collection of symptoms. It's affecting the coronary arteries, and we know that it's acute. It's not chronic. And it's an emergency. We're not sure at first how big of an emergency. The three major types of acute coronary syndrome. There's a very severe form, and then there's the not as severe form. So we know this is a collection of signs and symptoms that's a result of not enough blood flow to the heart. So usually this is going to be related to atherosclerosis. It could be coronary artery disease. And on occasion, it could be something like spasm, Prinzmetal angina, or something like that. But it happens suddenly. The person's going to be short of breath. They're going to have chest pressure, tightness, or pain. They might have back or neck pain. They might say that their pain radiates into their arms, their jaw, their neck. They might have some nausea and vomiting. They might have diaphoresis or be really sweaty. Really, there are a lot of different symptoms. And for every person, they can report very different symptoms, and especially in females, they tend to have pretty atypical presentations when it comes to acute coronary syndrome. It is interesting to note, though, that while we say that females tend to have different symptoms, the older a female gets, the more like males her symptoms become. The younger a female is, the more atypical symptoms she may have. So she may just be extremely fatigued and may have a little back pain here and there, and that may be symptoms of acute coronary syndrome. However, you can also have a female that presents with the classic symptoms, with crushing chest pain and diaphoresis and nausea and vomiting. So what are the types of acute coronary syndrome? Well, there's unstable angina or angina. There's non-ST segment elevation myocardial infarction. This is a heart attack, a type of heart attack. And then there's an ST segment elevation myocardial infarction, which is also a type of heart attack. And the non-ST segment, sometimes we refer to as a non-STEMI, STEMI being STEMI. And then the ST segment elevation myocardial infarction we may call a STEMI or an STEMI. Now, there are two major things that we have to determine what kind of acute coronary syndrome the person has. So when they come in, they have these symptoms, we're going to do a 12-lead ECG, and that 12-lead is going to give us an idea of what could possibly be going on. So I'm going to get my little laser pointer out here. And there are 12 major sections, which I'm pointing out here, of the 12-lead ECG. And each of the sections minus one, we won't get into really 12-lead right now interpretation, but all of the sections minus one really give us information about specific parts of the heart. So if you look at this image up here, we have electrodes that go across the chest, and then we also have one on the arms and a lead on each of the legs. So these leads will show us each a different section of the heart, if you will. So if there's blood flow blockage to certain parts of the heart, we're going to see that on different parts of the ECG. This is a normal 12-lead ECG, so you're not seeing any issues here. The other component is blood work. Troponin I, troponin T, usually an institution has one or the other. You don't usually see both of them done. And really, when you look at this graph, they're about equal. There are some differences, but for the most part, they're about equal. And there's also myoglobin, CKMB, and LDH. These are older markers for a heart attack, for an MI. But really now troponin is the gold standard. And so we see here that after an MI occurs, which is kind of this bottom axis here, the troponin levels are going to peak pretty rapidly. So the higher up this line goes on this y-axis, the higher the level of troponin. So troponin, definitely after 3 hours, we're going to start to see a rise. And by kind of that 6-hour mark, you really start to see high levels of troponin. So we're going to look at blood work as well when we evaluate this acute coronary syndrome. So this is going to be kind of the algorithm to take you through diagnosing a patient with what kind of ACS they have. So patient comes in here at the top. That's number one. They have symptoms, chest pain, tightness, pressure, and so forth. What we're going to do, like I said, we're going to get a 12-lead ECG and blood tests. If we look at the 12-lead ECG and we see ST segment elevation, they're immediately going to be considered to have an ST segment elevation MI. We don't even have to get the blood work back. If we do that 12-lead and we see that there's ST segment elevation, we are going to say they have a STEMI. This person needs to go to the cath lab immediately. They need to have usually a stent placed so that they can, at least one stent placed, sometimes more than that, so that they can open blood flow back up to the heart. Occasionally they may need emergent surgery for a bypass. Okay, if we do the 12-lead and we have some T-wave inversion, ST segment depression, or a combination of ST changes, not ST segment elevation, but some other small changes, it may be a non-ST segment elevation MI. So they may have had an MI, or it could be unstable angina. So here we have to look at the blood tests, blood work. Likewise, if we do the 12-lead ECG here and it's normal, we don't see any changes at all, it can still be a non-ST segment elevation MI, but it could also be unstable angina. And so the blood work is where we're going to find out. If that troponin, or the CKMB, which I mentioned was another possible test that they'll run, if that troponin rises over time and then falls back down, we're going to consider this person to have had a non-ST segment elevation MI. So troponin, if we see it, it basically means they've had an MI. If we don't see any troponin rise and fall, or CKMB that rises and then falls back to a normal value, we're going to call that unstable angina. So this person has come in and they have the symptoms, but they have not had an MI because the troponin didn't go up at all. If that troponin rises, but there was no ST segment elevation, we know they've had an MI, but it's a non-ST segment elevation MI because there is no ST segment elevation. If, however, they have ST segment elevation, they have had a STEMI, or an ST segment elevation MI. Now, I've noted kind of in this box, and I know it's probably kind of hard to see, you're 99% of the time, probably more than that, going to see that the troponin goes up with an ST segment elevation MI. But if that person comes in and they're having this terrible chest pain and we do a 12-lead ECG and see they have this ST segment elevation, they're probably going to be sent straight to the cath lab even before we get any blood test results back. So while that blood test will probably show that there's an elevated troponin that rises over time and then comes back down, we really don't care at that point because we know they need to get to the cath lab immediately.